Hello and welcome back. I'll be talking about imaging in the diagnosis of acute aortic syndromes. This will be part 2.1 in an approach to chest pain. We'll be discussing my imaging algorithm in suspected aortic syndromes. Now, these are acute aortic syndromes, so typically imaging is not something that I get exposed to, but because I deal with a lot of large vessel vasculitis patients, acute aortic syndromes, and their initial diagnosis becomes relevant to me as well as generally internal medicine in the emergency department. So I use a mnemonic that is DISSECT, where D stands for dissection versus other acute aortic syndromes. Then we'll describe a Mercedes-Benz sign and what that entails. We'll talk about atherosclerotic ulcers versus penetrating atherosclerotic ulcers on imaging. I stands for identification of the primary intimal flap. S stands for size of the aorta and of the false lumen. SE stands for segment affected, that is what part of the aorta is affected, and extension of the dissection. We'll talk about Stanford A and Stanford B classifications. I'm not going to go into the DBK classification because that's not very relevant to us, but I would suggest you look it up. We'll talk about some complications that are apparent on imaging, such as cardiac tamponade and branch vessel occlusion by dissection. We'll talk about thrombosis within affected vessels, that is T. There are two eponymous signs that have been described in aortic dissections. These will be discussed in this video. And then finally, we'll talk about a general approach to the diagnosis of aortic aneurysms on imaging. And actually, that is not an acute aortic syndrome, but I'll be talking about this primarily because of how on imaging an aneurysm may or may not occur with dissection. So this is the algorithm that I use. D stands for first look for a dissection and or identify other aortic syndrome. I stands for identify the intimal flap. S stands for size of aorta and of the false lumen. So for this, we have to identify the false lumen. S again stands for segment of aorta affected. E stands for extension of lesion, that is how much of the aorta is affected. C stands for complications present, and T stands for thrombus present. Now D, is it a dissection or not a dissection? In this case, you can see I've highlighted the false lumen in red. This is a Stanford A aortic aneurysm, and we'll come to what that means. This is a CECT arterial phase image showing a flap and a false lumen. Now, importantly, the lumen has higher contrast concentration and therefore is brighter, but usually is smaller because the blood, as it rushes into the restricted space within the false lumen, that is here, it is at a higher pressure than in the true lumen. That is what causes the size of the true lumen also to decrease in size. The other thing that is noticeable is that the true lumen is usually on the left of the aorta, so on this side, and the false lumen is usually on the right of the aorta. These are some of the things that we use to differentiate. One last point that is used to differentiate a false from a true lumen is the presence of cobwebs that are attaching the endothelium to the wall. So that naturally indicates that the endothelial wall has been stripped away from the wall of the aorta. This is a sagittal section showing the same. I have highlighted a particular portion at the start of the dissection. This is what is called the aortic beak sign. In this CCT sagittal section, the angle formed by the endothelial as well as the neural walls of the false lumen make a acute angle, that is less than a 90-degree angle with each other. So that is what is called the aortic beak sign. Now there's another sign called the Mercedes-Benz sign. This is formed by three lumens being present within the vessel, with two of the lumens being false lumens. This basically represents a second dissection developing in the media of the first dissection. So I'll just highlight that. This is notably different from the Mercedes-Benz sign that we see on the 2D echocardiography of the root of the aorta, which is normal. Penetrating atherosclerotic ulcers have to be differentiated from atherosclerotic ulcers without penetration. So this is based on the internal surface, the ulcer depth, the ulcer neck, that is how large the ulcer neck is, and the presence of intramural hematomas. So in case of atherosclerotic ulcers, the internal surface of the ulcer is undulating. Ulcer depth does not extend into the media, although this can be difficult to differentiate. Ulcer neck is very wide, and intramural hematomas are usually not present in the same area as the ulcer. In case of a penetrating atherosclerotic ulcer, the internal surface is smooth because it is penetrated up to the media. The ulcer extends into the media, again can be difficult to differentiate. Ulcer neck is very narrow, and intramural hematomas may be present and often are. So this is what a atherosclerotic ulcer would look like. So as you can see, the internal silhouette is undulating. And this is a true penetrating atherosclerotic ulcer. So as you can see, there is a proper penetration here with a narrow neck, and there is an intramural hematoma that is right next to it. These are the things that suggest it is a penetrating aortic ulcer. I stands for intimal tear identification. So we have a high attenuation crescent sign here. I've highlighted that in red. Thickening of the aortic wall with subtle hyperintensity, which was measured at around 60 to 70 Hounsfield units as compared to the lumen, is present. This is on a non-contrast CT. That is why it is important to take a non-contrast CT prior to giving contrast, even in patients with known or suspected acute aortic syndromes. A narrow window is often required to visualize the structures, that is the hematoma, because it may have a very similar attenuation to the lumen of the aorta. Now here, once we give contrast, there is no intimal flap that is identifiable. It appears like aortic thickening, but it's not a thickening, it's actually an intramural hematoma. So as I said, it is less apparent on contrast enhanced imaging, as the differences between contrast attenuation of the wall and the hematoma are far less than the difference between that in the contrast filled aorta and the wall or the hematoma. So this is basically an intramural hematoma without a identifiable intramural flap. S stands for size of aorta and false lumen. So these are the parts of the aorta. We've got the ascending aorta here, we've got the descending thoracic aorta, and we've got the transverse aorta that I've identified in yellow. Aortic diameter is measured at the following levels by convention. The first is at the sinuses of Valsalva. Second is at the sinotubular junction, that is where the sinuses of Valsalva join with the ascending aorta. Third is at the mid-ascending aorta, as is at the level of the pulmonary arteries. Fourth is the arch of the aorta at the level of this left subclavian artery origin. Fifth, we have the descending aorta at the level of the pulmonary artery. Sixth, we have the descending aorta at the level of the aortic hiatus of the diaphragm. So these are the 6 locations at which we measure the thoracic aortic diameters. If I enlarge the view that we took of the sinuses of Valsalva and turn it over, this is what it looks like. When you're measuring the aorta within the sinuses of Valsalva, the structures are not exactly a circle. So what we do is we actually measure the distance from the ostium to the opposite commissure. So in this particular section, this would be posterior, this would be anterior. And as you can see, the right coronary artery ostium is opening posteriorly, the left coronary artery ostium is opening to the left, whereas the non-coronary sinus naturally does not have an ostium. So here we draw a line from the commissure opposite the ostium to the ostium, and that is what represents the diameter. So this is called the cusp to commissure distance. Segment affected, basically we'll talk about the Stanford type A and Stanford type B dissections. So any dissection affecting the ascending aorta would be a Stanford A dissection. Any dissection affecting the aorta distal to the left subclavian artery is the Stanford B dissection. Stanford A dissections usually require surgical management. Stanford B do not. So usually a Stanford B aortic dissection can be managed medically. And in terms of complications, there are a few complications that can be picked up on imaging. So we have aortic dissection here with a mediastinal or pericardial blood collection, as you can see. The blood being at a higher mean pressure than the pulmonary artery is starting to compress the pulmonary artery. This is actually the pulmonary artery, and this is reducing flow to the lungs, resulting in a type of obstructive shock. Then aortic dissection with compromise of the left renal artery in this particular image shows focal infarction of the left kidney, as I've shown here. So in this particular section, this is the abdominal aorta, that is the subclavian artery, that is the renal arteries, and then we have the superior mesenteric artery with the dissection flap in it. As the dissection flap goes down, you can see that the lumen is lost and there is a thrombus within the lumen of the superior mesenteric artery most distally. In sagittal sections of the same patient, you can identify the thrombus. So I've identified the contrast opacified parts of the aorta and the superior mesenteric artery and celiac arteries. So as you can see, the origins of the celiac and superior mesenteric arteries appear normal in the first image. In the second image, you can see that there is a dissection flap in the superior mesenteric artery. I've highlighted it in blue, distal to its origin. And finally, we have a thrombus that is occluding the superior mesenteric artery distally. So naturally, this patient would have presented with an acute aortic syndrome complicated by acute obstructive mesenteric ischemia. Finally, there are two named signs in aortic dissection: the aortic Windsock sign, which is basically a intimo-intimal intussusception. There are two lumens, both of which are actually false lumens. So in this, both of the lumens that I have shown are actually false lumens, and one false lumen is extending into another. So that represents an intimo-intimal intussusception. There is also something known as the aortic Cobweb sign. This is seen as a fine web-like structure that is within the false lumen. This is often used to identify the false lumen, but is often not present and can make identification difficult. So the cobweb-like structures are basically strands of tunica media that have not been completely sheared off from the internal. When it comes to aortic aneurysms, I'll just talk about the general imaging approach that I use. We'll go into more detail when we talk about imaging in Takayasu in our discussions on clinical immunology and rheumatology. So if you have a multifocal aneurysm, the most common cause is actually Takayasu aortoarteritis. Less commonly, it is aortic coarctation. If it's not multifocal, then what we look at is vessel changes. That is there thickening and or enhancement versus is there calcification. If neither is present, then it's most likely a genetic connective tissue disorder. If only thickening is present, then it may be an infection or it may be a non-infectious inflammatory disorder such as Takayasu and other giant cell arteritis as well as atherosclerosis. Now, when it comes to calcification without thickening, that is naturally atherosclerosis. And if both are present, then it can be atherosclerosis, a large vessel vasculitis, or syphilis. In this case, naturally, the Takayasu or other large vessel vasculitis have been there for a long period of time, and syphilis has been there for a long period of time. So, the clinical presentation and how rapidly the patient presented also needs to be considered while considering the validity of these imaging findings. Now, infective aneurysms may also have gas within the aortic wall. This is something that is odd but strongly suggests infection. So in this video, I have discussed an imaging algorithm for acute aortic syndromes using the mnemonic DISSECT, D for standing for dissection. We've discussed the Mercedes-Benz sign to differentiate atherosclerotic ulcers from penetrating atherosclerotic ulcers on imaging. We've identified the primary intimal flap, or actually the lack of that in case of an intramural hematoma. S stands for size of the aorta and the false lumen. SE stands for segment affected. We talked about Stanford A versus B classes and why that is relevant for management. C stands for complications, that is cardiac tamponade versus branch vessel occlusion. T stands for thrombus within the affected wall. So these are the three complications that are visible on imaging. Then we talked about two eponymous signs, that is the Windsock sign as well as the Cobweb sign. Then finally, I talked about a general approach to the diagnosis of aortic aneurysms on imaging, which is not strictly related to acute aortic aneurysms, but requires to be discussed under this heading because of how aneurysms can result in dissections and vice versa. So thank you for watching. And in the next video, we'll talk about pneumothoraces and their imaging before turning to the main causes of chest pain that come to internal medicine.